Okay, let's unpack this. Imagine a horse in serious pain. The classic colic signs.
Right. Pacing, rolling.
Exactly. But they can't point to the spot. They can't tell you if it's a dull ache or something sharp like a twist.
No, you're flying blind in that sense.
And when it comes to colic, time isn't just important. It can literally be the difference between life and death. Vets need crucial information, and they need it fast.
Absolutely. It's one of the most challenging scenarios in veterinary medicine, really. You've got this huge animal clearly in distress, and you need to figure out exactly what's happening inside quickly and accurately.
Without asking them.
Yeah.
Without asking them.
Right. So how do you get that vital snapshot of what's going on internally? That's where our deep dive takes us today, into a procedure people often call the belly tap.
Mm-hmm. The belly tap, formally it's abdominocentesis or a peritoneal tap.
Okay. And at its heart, it's basically collecting a tiny sample of the fluid that surrounds the organs inside the abdomen, right?
Oh.
Exactly. Think of it like getting access to a secret intelligence report that's being generated right inside the horse's own body.
A secret report, I like.
Yeah. And the mission for us today, looking at the sources you shared, is to really understand why this report is so critical, why this belly tap is considered invaluable,
Okay.
and also how we actually get that report safely, and maybe most importantly, what the information in that little bit of fluid tells us about the big, complicated stuff happening inside the horse.
And maybe the most urgent piece of intel this procedure gives us, and the sources really hammered this home, is helping tell the difference between different kinds of colic.
Oh, absolutely crucial.
Like, is it medical colic, something you might, fingers crossed, be able to treat with meds? Or is it surgical colic, something really bad like a twisted gut or even a rupture that needs immediate, now life-saving surgery?
Precisely. This fluid analysis is so often the single most critical piece of information that pushes a vet towards that urgent decision point. Do we go to surgery now, or can we try medical management first?
It's the pivot point.
It really is. In so many colic emergencies, it's the diagnostic pivot point.
Okay, so colic is the big one, obviously. But the sources show there are other reasons a vet might do a belly tap. What else can this fluid tell us?
Well, you might do it if you suspect peritonitis, that's inflammation or, infection in the abdominal lining.
Ah, okay.
It can sometimes be helpful for figuring out the cause of unexplained chronic issues, though, maybe less commonly just for weight loss or diarrhea on their own. But if you have a fever of unknown origin that might be tied to something abdominal,
That makes sense.
or if an ultrasound has already shown there's extra fluid sloshing around in there,
Yeah.
this helps figure out what that fluid is.
Characterize it.
Exactly. And it's also a way to check for complications after abdominal surgery, or if you suspect internal bleeding hemoperitoneum, we call it.
Okay, so it's a pretty versatile tool for checking things out internally. But, tapping into the abdomen, it sounds like something you need to be pretty careful about. Are there times when you wouldn't do it? Or times it's riskier?
Oh, definitely, yeah. While it's generally safe, there are situations where you need to be extra cautious. For instance, if a horse has a loop of really badly distended intestine pressed up against the belly wall, where we'd normally tap.
Oh, you wouldn't want to hit that.
Exactly. The risk of accidentally poking the gut goes way up. Also, if the horse is in so much pain or is so agitated that they just can't stand still or be safely restrained, well, that's risky for everyone involved.
For the horse and the vet.
Absolutely. You'd also want to avoid it if the horse has a known serious bleeding disorder. And sometimes if there's a lot of swelling, like edema in the belly wall itself, it can make finding the right landmarks tricky and increase the chance of getting a sample that's, contaminated from the skin or wall.
Okay.
So good restraint, maybe some light sedation, that's really key to keeping things safe.
That makes total sense. Safety first, always. Okay, let's shift gears to how this report card from the abdomen is actually collected. Walk us through the procedure itself.
Sure. So typically it's done on a standing horse, often with that light sedation we mentioned,
Yeah.
and maybe a twitch for a little extra behavioral control.
Okay. And the kit. What does a vet need to have ready to go?
You need your standard surgical prep stuff, clippers, antiseptic scrub, like chlorhexidine or povidone iodine.
Get it clean.
Yep, got to be aseptic. Some vets will use a local anesthetic like lidocaine to numb the skin patch. Others might skip that for speed, especially in an emergency.
Mm.
Sterile gloves and gauze are a must.
Right.
You need a small scalpel blade, usually like a #15, to make a tiny stab incision just through the skin. And then the critical part, the instrument to actually get into the abdomen.
Yeah.
This is usually something blunt tip, like a metal teat cannula or a plastic bitch catheter.
Blunt is better.
Often preferred, yeah. Especially in foals or just generally to lower the risk of, poking something important. An 18-gauge spinal needle can be used too, but blunt is often the go-to.
Gotcha.
And then your collection tubes, super important. You need a purple top tube that's got EDTA in it.
Why purple?
The EDTA stops the fluid from clotting. That's essential if you want to get an accurate cell count and look at the cells properly under the microscope cytology.
Okay, EDTA prevents clotting. Makes sense.
Then you need a red top tube, which has no anticoagulant. That's for measuring things like total protein or running other biochemical tests like lactate and glucose, and for sending off a sample for bacterial culture if you suspect infection.
Gotcha. Okay.
And sometimes, if you really suspect sepsis, you might even use special blood culture bottles to collect the fluid.
Okay, the sources really seem to focus on picking the right spot as being super important. Where's the usual place to tap, and why there?
Yeah, location is key. The standard site and what the sources recommend as the safest bet is about maybe an inch or so, 2 to 4 centimeters to the right of the ventral midline, the bottom center line of the belly.
Oh, right.
To the right. And just behind the rib cage area, technically caudal to the xiphoid process, which is the bottom tip of the sternum.
And why slightly off-center to the right?
It's strategic. It helps you avoid hitting the spleen, which in horses hangs down mostly on the left side.
Ah, okay.
It also reduces the chance of hitting major blood vessels or a distended large colon, which often sits more centrally or can shift left during colic. So that spot on the right is often called the safe zone.
The safe zone, got it. And I noticed the sources really push for using ultrasound guidance whenever possible. What's the big advantage there?
Oh, ultrasound is just a total game changer for this, seriously. It lets you actually see what's under the skin before you go in.
Like X-ray vision?
Sort of.
Mm-hmm.
You can visually find the best pocket of fluid to aim for. You can actively steer clear of loops of distended bowel that might be floating around.
Which could move.
Exactly. And you can check that there aren't any adhesions, sticking bits of gut or something to the belly wall right where you plan to tap. It's especially helpful in trickier cases, like maybe an obese horse or one where there isn't much fluid to begin with.
Right. Makes it less hit or miss.
Totally. It just adds a massive layer of safety and confidence to the whole procedure.
Okay, so you've prepped the site, maybe used local, picked your spot, ideally with ultrasound, confirming it looks good. What happens next? What does the actual insertion feel like?
So you make that little stab incision through the skin, maybe just nicking the superficial muscle layer with a scalpel. Then you take your blunt cannula or needle and gently insert it through that incision. As you pass through the layers, skin, muscle, abdominal wall, and then the peritoneum, which is the lining of the abdomen, you'll usually feel a distinct, subtle pop.
The pop?
Yeah, or like a sudden release of resistance as you break through that peritoneal membrane and enter the abdominal cavity itself.
Okay.
At that point, if there's fluid present, it should ideally just start dripping out of the cannula.
Mm-hmm.
If it doesn't drip right away, sometimes a tiny bit of repositioning, like angling it slightly differently.
Or a very, very gentle suction with a small syringe can help get it flowing. You don't want to suck hard, though.
Right, just coax it.
Okay.
All right, we've got our precious few milliliters of fluid. Now, the really fascinating part, reading that secret intelligence report, as you called it. What does normal peritoneal fluid tell us? What should it look like if everything's basically okay inside?
Okay, so in a healthy horse, first off, you're probably only going to collect a small amount, usually just a few milliliters. There's typically less than 100 milliliters total fluid in the whole abdomen normally.
Not much, then.
Not much at all. It's just for lubrication.
Yeah.
And grossly meaning just looking at it should be clear. Like you should be able to read newspaper print through the tube.
Okay, clear.
And the color should be colorless to maybe a very pale yellow, sometimes called straw color.
Straw color.
Yep. It should have absolutely no odor. And critically, normal peritoneal fluid should not clot.
Doesn't clot.
No.
Okay, so clear, pale yellow or colorless, no smell, doesn't clot. That's a good baseline. What about when you look closer, the lab analysis, the numbers, the cells?
Right. This is where the specific details from the sources really come into play. The total protein level should be quite low, typically less than 2.5 grams per deciliter or 25 grams per liter.
Low protein.
Very low. And the total nucleated cell count, or TNCC, basically all the cells that aren't red blood cells, that's also low, usually less than 5,000 cells per microliter.
Under 5,000 cells.
Correct. And when you actually look at what those cells are under the microscope, the cytology, you'll see mostly neutrophils.
Yeah.
But importantly, they should be non-degenerate neutrophils.
Non-degenerate, meaning they look normal, healthy.
Exactly. They haven't been damaged by bacteria or toxins. They make up maybe 40 to 80% of the cells. The rest are mostly mononuclear cells, things like macrophages and lymphocytes. You might see very few red blood cells, but really not many. And you'll usually see some mesothelial cells, which are just the normal cells that line the abdominal cavity. Other normal values include a low specific gravity. The fluid isn't very concentrated. Lactate levels should be similar to what's in the blood, usually less than 2.0 millimole. And glucose and pH should also be pretty close to blood values.
It's really amazing, isn't it, how this fluid is just constantly being made, this ultrafiltrate of plasma, just keeping things slick inside.
It is. It's lubricating the organs.
So any change in what it's made of is like a direct signal, a direct reflection of the environment inside the abdomen, right?
That's exactly it. It's like the body's constantly leaving little clues in this fluid, and our job, with the help of the lab, is to read those clues.
Okay, let's get to the real detective work then. What does abnormal fluid look like? What are the big signals the sources point to that tell us something is seriously wrong? This is where we start cracking the code.
Right. This is where the power of this test really shines. We look at changes in how it looks, the gross appearance, but the truly critical insights come from the numbers, the cell counts, the cytology, and those other tests. Let's start with just looking at it.
Okay. Color, odor. What are the red flags we can see?
Well, if the fluid is pink or red, or what we call serosanguinous, that means it looks kind of like watery blood or blood-tinged serum.
Pinkish red.
Yeah. That can suggest bleeding. It could be just a little contamination from the tap itself if you make the vessel.
Okay.
But more worryingly, it's often a sign of vascular damage or compromise to the gut wall, like you see with a twisted intestine and strangulation.
That makes sense. Blood leaking out.
Exactly. Now, if the fluid looks brown or green or flocculent, meaning it has little clumps or flakes floating in it,
Ooh, that doesn't sound good.
that's a much more serious sign. It often points towards intestinal rupture, where gut contents are spilling out, or really severe tissue death, necrosis. Although you can sometimes get that appearance if you accidentally puncture the gut during the tap itself.
Right. Need to distinguish that.
Yes. If the fluid is turbid or cloudy, just generally hazy.
Can't read the newspaper through it anymore.
Right. That tells you there are increased numbers of cells or increased protein or both. It signals inflammation or infection. If it looks milky, that could potentially be something called chyle, but that's less common.
Okay.
Deep yellow fluid can sometimes be normal in horses that haven't been eating, but if it's deep yellow and cloudy, you should be thinking inflammation again.
What about smell? You said normal has no odor.
Correct. So if it has a foul or feculent odor, smells like manure,
Oh boy.
that is a major, major alarm bell. Highly suggestive of intestinal rupture or severe septic peritonitis, a massive infection. And if it smells like urine, that points pretty clearly to uroperitoneum, a ruptured bladder or ureter. We see that sometimes, especially in young foals.
Wow, the smell alone can tell you a lot. And you mentioned normal fluid doesn't clot, so if it does clot...
Also definitely abnormal. If the fluid clots after you collect it, even in the red top tube, it means there's been significant leakage of clotting factors like fibrinogen into the abdominal cavity. That happens with substantial inflammation or significant bleeding. Not normal at all.
Okay, so the visual cues and the smell give us some strong hints, but you said the numbers and the cell types really tell the detailed story. Let's walk through what the sources highlight for different specific conditions. How does the report read for, say, a strangulating obstruction? That sounds like a critical one.
It is. This is where the key diagnostic insights really lie. Let's break it down. For a simple obstruction, like just a blockage without cutting off blood supply, especially early on, the fluid might not look dramatically different, maybe just slightly cloudy or turbid. The protein might be a little bit elevated. The cell count, the TNCC, might be slightly up, say, in the 3,000 to 8,000 cells per microliter range. But things like lactate are usually normal or only minimally elevated, maybe less than 3.0. And the neutrophils you see look normal, non-degenerate.
Okay, so subtle changes for a simple blockage.
Often, yes, especially early. But now contrast that with a strangulating obstruction where a piece of gut has twisted or gotten trapped, cutting off its blood supply. This is ischemia, leading to necrosis or tissue death. Here, the fluid changes dramatically. It becomes serosanguinous, that pink, red, or even brownish color, and definitely turbid. The protein level jumps up significantly, maybe 3.5 to 6.0 GDL or even higher. The cell count, TNCC, is also significantly elevated, could be anywhere from 5,000 up past 50,000. You see more red blood cells leaking in.
Okay, more protein, more cells, reddish color.
Right. But the absolutely critical finding, the one that sources really emphasize as a powerful indicator for strangulation, is the lactate level in that fluid.
Lactate, why is that so important?
Because lactate is produced when tissues aren't getting enough oxygen. So if a piece of gut is being strangled, it's not getting blood, it's not getting oxygen, and it starts producing a lot of lactate, which leaks into the surrounding fluid.
Ah, okay, so high lactate means oxygen starvation.
Exactly. In a strangulating obstruction, the peritoneal fluid lactate is markedly elevated, often over 4.0 millimole, sometimes way over 10.0 millimole. And importantly, if you were to take another sample an hour later, it would likely be even higher. It's rising.
Rising lactate, that's a key point.
Huge point. And then when you look at the cytology, the cells under the microscope, you start seeing degenerate neutrophils.
There's that term again. What do they look like?
These are neutrophils that look damaged. Their nucleus might be swollen or breaking apart. Their cytoplasm might look vacuolated or foamy. It's a key signal that either bacteria or their toxins are present, or the cells themselves are just dying because of the toxic environment or lack of oxygen from the ischemic gut.
Okay, so high lactate plus degenerate neutrophils. That's the big combination from the sources screaming, surgical emergency. Get this horse to surgery now.
Precisely. Those two findings together are hallmark signs of ischemia, impending necrosis, or sepsis related to the gut wall being severely compromised. That's the kind of definitive information that drives the decision for immediate surgery. You can't wait.
Wow. Okay, what about the absolute worst case scenario, like an intestinal rupture?
Yeah, intestinal rupture. This is extremely serious, as you can imagine. The fluid is typically grossly abnormal, highly turbid, often brown or green, usually with that foul, feculent odor. And you might even see visible particulate matter like feed material.
Actual gut contents.
Actual gut contents floating in the abdominal fluid. Unsurprisingly, the protein and cell counts are extremely high. TNCC can be astronomical 50,000 up to 500,000 cells per microliter or even higher. Lactate is also typically very, very high.
And the cells?
The cytology is pretty much diagnostic. You see an overwhelming percentage, often over 90%, of degenerate neutrophils. You find intracellular bacteria, meaning bacteria inside the neutrophils, which shows the body is trying, usually futilely, to fight this massive infection. You see tons of extracellular bacteria too, and often you literally see things like plant fibers or feed particles mixed in with the cells on the microscope slide.
Just looking at the slide tells you it's ruptured.
Often, yes. And sadly, this typically indicates a grave prognosis. Surgery is usually not an option at this point.
That's tough. Okay, intracellular bacteria. You mentioned that means the body's fighting infection. What about peritonitis generally? Infection in the abdomen.
Right. So septic peritonitis, meaning infection within the abdominal cavity itself, maybe from a migrating foreign body, an abscess, contamination from surgery, or sometimes leakage from damaged gut that hasn't fully ruptured yet.
Okay.
Here, the fluid is turbid again. It could be yellowish, orange, sometimes even whitish or creamy, and it might have a foul odor, though maybe not as bad as a full rupture. Protein is high, usually over 3.0, often over 5.0 GDL. TNCC is very high, easily over 10,000, often much higher, into the hundreds of thousands. Lactate is usually elevated, often over 4.0, sometimes over 12.0.
And the key cell finding?
Again, it's that very high percentage, typically over 90% of degenerate neutrophils. And crucially, you find intracellular bacteria within those neutrophils. Seeing bacteria inside the phagocytic cells is strong evidence of an active septic process. You'll usually see extracellular bacteria too.
So degenerate neutrophils plus intracellular bacteria equals septic peritonitis.
That's the hallmark combination, yes.
What if you have inflammation, but it's not caused by bacteria? Is that possible?
Yes, that's what we call non-septic peritonitis. This can be caused by, say, chemical irritation, maybe a reaction to blood in the abdomen, or certain types of cancer, or even some gut motility issues that cause inflammation without infection.
Okay. How does the fluid look different?
The fluid is usually turbid and often yellowish. Protein is elevated, maybe over 2.5 GDL. TNCC is high, often over 10,000. So you have inflammation. But the key difference from septic peritonitis is when you look at the neutrophils.
Ah, are they non-degenerate?
Exactly. In non-septic peritonitis, the neutrophils are predominantly non-degenerate. They look relatively healthy. And you typically don't find bacteria. Lactate is usually normal or only mildly elevated.
Okay, so the state of the neutrophils is a huge differentiator between septic and non-septic inflammation.
Absolutely critical distinction.
What about just bleeding? You mentioned hemoperitoneum earlier.
Right, hemoperitoneum, that's actual significant bleeding into the abdominal cavity. Maybe from a ruptured vessel, a tumor bleeding, or trauma. The fluid will look uniformly bloody, like straight blood or slightly diluted blood.
How do you tell that apart from just hitting a small vessel during the tap? Because that can make the sample bloody too, right?
Good question. The key is to check the PCV, the packed cell volume, which is the percentage of red blood cells of the fluid sample, and compare it to the horse's peripheral blood PCV, taken from a vein. In true hemoperitoneum, the fluid's PCV will be similar to, or at least a significant fraction of, the horse's blood PCV. If you just had a little bleeding contamination from the tap itself, the fluid PCV will usually be much lower than the blood PCV, and it might decrease rapidly if you collect sequential drops.
Ah, okay. Comparing the PCV tells the story. Makes sense.
And finally, uroperitoneum urine leaking into the abdomen, usually from a ruptured bladder, especially in foals. The fluid is often clear to yellowish and typically smells distinctly like urine. Protein and cell count are usually low, surprisingly.
Low. Why low?
Because urine itself doesn't usually have high protein or many cells unless there's also a urinary tract infection. The definitive diagnosis for uroperitoneum actually comes from those ancillary tests, specifically comparing fluid chemistry to blood chemistry.
Which brings us perfectly to those ancillary tests and ratios you mentioned before. Comparing fluid values to blood values seems like a really smart way to confirm or pinpoint the specific problem.
Oh, absolutely. These comparisons can be incredibly revealing. The lactate ratio is probably one of the most powerful examples highlighted in the sources, especially for colic.
How does that work again?
You measure the lactate level in the peritoneal fluid, and you measure the lactate level in the horse's blood at the same time. If the peritoneal fluid lactate is significantly higher than the blood lactate, the sources often mention a ratio greater than 2.1, or simply the fluid lactate is over 4.0 millirel and potentially rising while blood lactate might be lower. That's a very, very strong indicator of gut strangulation or ischemia. The compromised gut is pouring lactate into the local environment faster than it can be absorbed or diluted.
So fluid lactate, much higher than blood lactate, screams strangulation.
It's a huge red flag. And doing serial tests, checking it again an hour later, is especially powerful. If that gap is widening, that's really bad news.
Okay. What about the glucose comparison?
The glucose difference is also really useful, especially if you can't get cytology results back immediately. Maybe you're out on a farm call. You compare the glucose level in the fluid to the glucose level in the blood.
And what are you looking for?
If the fluid glucose is significantly lower than the blood glucose, for example, if the fluid glucose is less than 30 milligdl, or if there's more than a 50 milligdl difference between the blood and fluid levels, with the fluid being lower,
Okay.
it means something in the abdomen is rapidly eating up the glucose, and the usual culprit is bacteria.
Ah, bacteria consume glucose.
Exactly. So a large glucose difference with fluid glucose being much lower than blood glucose points strongly towards septic peritonitis. It's a quick biochemical clue to infection.
That's clever. What about for the urine leak, the uroperitoneum?
That's where the creatinine-urea ratio comes in. Urine normally contains very high concentrations of creatinine and urea waste products filtered by the kidneys. Blood has much lower levels.
Right.
So if you measure creatinine or urea in the peritoneal fluid and compare it to the level in the blood serum, and the fluid level is much higher, especially if the ratio of fluid creatinine to serum creatinine is greater than 2.1. It's basically diagnostic for uroperitoneum. It confirms urine is leaking into the abdomen.
Crystal clear evidence.
Pretty much undeniable. And lastly, if you do suspect infection, whether it's septic peritonitis or maybe leakage after hitting the gut, sending some of that fluid from the red top tube or a special culture swab bottle for culture and sensitivity is crucial.
To find out exactly what bug it is.
Exactly. Identify the specific bacteria causing the problem, and just as importantly, determine which antibiotics are actually going to be effective against that particular strain. That guides your treatment plan.
Wow. It really is incredible how much concrete, actionable information you can pull out of this one small sample by looking at all these specific parameters and comparing them. So pulling it all together then, why is this belly tap considered so fundamentally important in equine practice based on what the sources really showed?
Well, I think it boils down to this, especially in colic cases, which are so common and so critical. Abdominocentesis provides the most sensitive and often the earliest way to detect intestinal strangulation. And that information directly guides the absolutely critical decision about whether or not to pursue surgery and how urgently.
It drives the surgery decision.
Hugely. It also allows for definitive confirmation and characterization of peritonitis, figuring out if it's infectious or not, which completely changes how you treat it. It can diagnose intestinal rupture, which although the prognosis is usually grim, is still vital information for the owner and for deciding on euthanasia.
Gives closure, maybe.
It does. And it's also vital for monitoring. If you have a horse you're trying to treat medically for colic, watching how the fluid parameters change over time, are the cell counts going up, is the lactate climbing. That can signal if the condition is actually worsening and maybe surgery is becoming necessary after all.
So it's not just a one-time snapshot. It can be used for monitoring, too.
Absolutely.
Yeah.
It's truly the fastest, most direct way we have to get that critical internal intelligence when dealing with abdominal crises in horses.
It really sounds like a diagnostic linchpin, doesn't it?
Yeah.
Now, we did touch on the risks earlier, but let's just talk a little more specifically about potential complications. Even with careful technique, ultrasound guidance, things can sometimes happen, right?
They can, yeah. It's generally safe, but not entirely risk-free. Probably the most common potential issue is accidentally puncturing the intestine during the tap. We call that iatrogenic enterocentesis.
Hitting the gut by mistake.
Right. It's more likely to happen if the gut is really badly distended and pushed up against a wall, or potentially if you use a sharp needle instead of a blunt instrument.
Is that always a disaster?
Not necessarily. If the gut wall itself is reasonably healthy and your technique was clean, aseptic, a small puncture often seals over quickly and doesn't always lead to a full-blown, life-threatening peritonitis. If you analyze the fluid right after it happens, you'll see plant material or gut contents and bacteria.
Evidence of the poke.
Yeah, but you might not initially see a massive inflammatory cell response from that specific puncture itself, though the underlying condition might still be causing inflammation. But again, using a blunt cannula, and especially using ultrasound guidance to actively avoid bowel loops, significantly reduces this risk.
Okay, so accidental poke is the most common. What about something more serious actually caused by the procedure itself?
Well, a rare but obviously very serious complication would be developing septic peritonitis because of the tap. This could happen if there was contamination introduced from the outside, maybe the skin prep wasn't perfect, or potentially if you puncture a section of gut wall that's already diseased and fragile, causing it to leak persistently afterwards.
How would you know that happened?
The horse would likely develop a fever, show worsening signs of colic or abdominal pain, and if you retap the belly, you'd see rapidly deteriorating fluid parameters, skyrocketing cell counts with lots of degenerate neutrophils and intercellular bacteria, indicating a new or worsening infection directly related to the procedure. But again, this is rare with good technique.
Okay, what else?
Other potential risks include just a localized infection at the tap site itself, like cellulitis or maybe a small abscess forming under the skin. You could hit a blood vessel in the body wall and cause some bleeding or hematoma. Or, as we mentioned, accidentally hitting the spleen.
Right, the spleen tap.
Yeah, that happens more often if you tap on the left side, or if the spleen is enlarged or displaced, like in a condition called nephrosplenic entrapment. A splenic tap gives you a sample that looks like pure blood, and its PCV will be similar to the horse's peripheral blood PCV right away. That sample isn't useful for evaluating the peritoneal fluid itself, unfortunately.
Invalidates the sample for analysis.
Correct. More severe trauma, like actually lacerating the intestine, is possible, but very rare, especially if you're using blunt instruments and the horse is well restrained. Horses with sand impactions might be at slightly higher risk of accidental gut puncture because the sand can make the bowel wall heavier and less mobile.
Interesting point about sand.
And just theoretically, in a pregnant mare, you could accidentally tap the amniotic sac instead of the peritoneal cavity, though significant problems from that specifically haven't really been reported in the literature. And finally, some horses might get a bit of swelling or edema right at the tap site, which seems to be slightly more common when using blunt cannulas compared to sharp needles, but it's usually minor.
Okay, so wrapping up this deep dive then, what's the main takeaway? What does this all show us?
I think it really shows us how a procedure that sounds relatively simple, just collecting a small amount of fluid from the abdomen, when you combine it with careful, detailed analysis of that fluid, looking at its color, its smell, the cell counts, the protein level, and especially those crucial comparisons like the lactate difference or the glucose difference compared to blood.
Those ratios.
Exactly, those ratios. It provides an incredibly powerful, rapid diagnostic tool. It's just essential for unlocking vital, often truly life-saving information when dealing with equine abdominal emergencies, especially colic.
Understanding these specific markers, degenerate neutrophils, lactate levels, intracellular bacteria, It really provides a clear roadmap for diagnosis and helps guide those absolutely critical treatment decisions, especially that huge one about whether or not surgery is needed, right?
Absolutely.
And for you listening, I hope this gives you a much deeper appreciation for the ingenuity and the real detective work involved in figuring out what's wrong inside an animal that relies completely on us, on vets, to interpret their signs of pain and distress.
Yeah, and maybe it leaves you with a fascinating thought to consider. How these tiny microscopic changes, subtle shifts in cell types, protein levels, small chemical imbalances measured in just a few milliliters of fluid, can actually reflect such dramatic, large-scale, and often incredibly rapidly unfolding events happening deep within the horse's body.
It's amazing, the connection.
It really is. And how quickly and accurately a vet, by interpreting those subtle signals in the fluid, can potentially tell the difference between a condition that might respond to medical treatment and a life-threatening surgical emergency where every minute counts. It just truly highlights the intricate balance within the body and the incredible diagnostic power we can get from paying extremely close attention to its subtle signals, like those found in the peritoneal fluid.